My name's Aboulafia, and I'm the Regional Medical Director for Cancer Service Line in Baltimore with the MedStar Georgetown Cancer Institute. I'm really excited to welcome everybody to this year's 2020 Multidisciplinary Cancer Symposium. This has been a remarkable year that none of us are soon to forget. But under Dr. Farha's leadership, we've organized a really great symposium that's responsive to some of the questions we've asked primary care and other providers what they're interested in learning. So this year, our symposium will center first around cancer screening. We'll be talking about cancer screening for the most common cancers that we treat, which are breast, colorectal, lung, and prostate cancer. And in the multidisciplinary spirit, we have experts from different disciplines. In breast cancer, we'll be having Dr. Townsend speak to us about cancer screening. Dr. Stein, our Chief of Surgery, will speak about colorectal screening. Dr. Kamugisha will speak about lung cancer screening, which is really a new and exciting area, particularly with some of the changes of the recommendations and insurance coverage for lung cancer screening. And then finally, we'll have Dr. Paul Fowler, a radiation oncologist, speak about prostate screening. Then we'll take a short break and we'll switch the second half of the symposium to Dr. Kearney, who will speak on palliative care for cancer patients. Dr. Mohebtash will talk about monoclonal gammopathies. And then finally, Dr. Farha, our course director, will speak about the impact of COVID-19 on cancer care. I'd also like to thank our two course co-directors, Dr. Mohebtash and Dr. Paul Fowler. We'll be taking questions live in the comments section throughout the symposium. Please let us know afterwards if there's anything we can do better. Enjoy the meeting. Thank you.
Good afternoon. My name is Dr. Day and I'm Chief of Breast Imaging, and today I'm going to speak to you about screening breast imaging. I have no financial disclosures. The objectives of this talk are that the participant will learn about factors affecting screening mammography utilization. The participant will learn about updated screening mammography recommendations for average-risk women, and the participant will learn about screening mammography recommendations for high-risk women. Breast cancer is a significant health risk worldwide with more than 2 million cases which occur annually. Breast cancer will develop in 1 in 8 women in their lifetime, and breast cancer is the second leading cause of cancer death in the United States for women. The public health policy which has had the greatest impact upon breast cancer mortality has been the advent of widespread screening mammography. The goal of screening mammography is early detection of stage 1 node-negative cancer. After the widespread utilization of screening mammography in the mid-1980s, there was a resultant decrease in mortality of approximately 40%. There are multiple factors which affect screening mammography utilization, and they include public health policy, which directly affects screening guidelines, access to screening mammography, as well as primary care physician and provider access and referral. With respect to public health policy, the USPSTF, which is the United States Preventive Services Task Force, in 2009 made a change to screening mammography recommendations. Prior to 2009, the recommendations were every 1 to 2 years beginning at the age of 40 with no end age limit. After 2009, the recommendations became screening mammography should occur in patients aged 50 through 74 every 2 years for screening schedule. The recommendation for patients aged 40 to 49 were that the decision to start regular biennial screening mammography before the age of 50 should be an individual one and take into context patients' tolerance for benefits and harms, and is a conversation to be had with a primary care physician or provider. This was given a grade of C. With respect to women aged greater than 74, the recommendation was an I, meaning that there was insufficient evidence for or against screening mammography in patients aged 74 or older. Medicare utilization post-USPSTF guidelines decreased to approximately 309 mammograms per 1,000 women from a peak of 322 mammograms per 1,000 women in 2009. Additionally, post-USPSTF, as physicians are not a monolith, multiple societies came out with their own breast imaging recommendations, which made recommending screening mammography for primary care physicians and providers even more confusing, and even more confusing was this information to the lay patient. This chart demonstrates breast cancer deaths avoided using randomized control trials and CISNET modeling. The top row demonstrates the fact that the breast cancer deaths that are avoided by screening mammography are much less than that is what's modeled with annual screening and biennial screening mammography as modeled by 2000 CISNET data. Additionally, or the most deaths avoided by breast cancer is by an annual screening schedule and not by a biennial screening schedule for all age cohorts. This slide demonstrates the benefits of the 3 recommended strategies. In 2016, the American Cancer Society deviated from the American College of Radiology and the Society of Breast Imaging Guidelines and changed their annual screening mammography to begin at between the ages of 45 and 54 and biennially after the ages of 55 to 79. So as you can see clearly, with a reduced number of screening, you will see that there's a reduced number of mammograms per 1,000 women, as one would expect with every other year screening. But the percentage mortality reduction is most beneficial beginning with annual screening mammography at the age of 40, with a mortality reduction of approximately 40%, as opposed to 23.2% in the USPSTF recommendation. Additionally, the life years gained per 1,000 women screened is 189 in the annually screened group, as opposed to 110 life years gained in the group that's imaged every other year from the ages of 50 to 74. And let's talk about the performance of screening mammography in patients that are older than the age of 74. As the patient age increases, the sensitivity of mammography does increase to about 95% in patients aged 90 or greater. But in that population of patients between 70 and 79, the cancer detection rate is 6.2 cancers per 1,000 women, with a CDR of 80.4% and a positive predictive value of 37.6%. This just means that annual screening mammography in patients aged greater than 74 behaves very well, and we find a high number of cancers in this patient population, which are typically small and are amenable to treatment. This graph demonstrates the years of life lost due to death from breast cancer by age of diagnosis. So you can see that the most years of life lost due to death are between 45 and 54. The USPSTF guidelines would exclude this cohort of women from the benefits of screening mammography, as well as this cohort of women aged 40 to 44 from the benefits of screening mammography. Access to screening mammography also is primarily a function of healthcare costs. So the Breast and Cervical Cancer Program is a nationwide program which enrolls patients who are uninsured and underinsured and affords them the opportunity of screening mammography. If subsequent diagnostic mammography and ultrasounds need to be performed, this program also covers the cost of those procedures, and the patient is enrolled in Medicare. The Affordable Care Act has a cost-sharing provision such that they cover the full cost of a screening mammogram. So the USPSTF recommendations of C and I in patients that are aged 40 to 49 and older than the age of 74 puts at risk healthcare coverage, as typically health insurance companies will cover screening recommendations that are graded A or B and may deny screening recommendations that have a C or an I. And additionally, approximately a third of patients and a third of Medicare eligible women in 2017 and 2018 did not undergo screening mammography. And some of the question is as to why, especially since there's a known mortality benefit. So primary care access has a great impact on access and invitation to screening mammography. So primary care physicians and providers are one of the best predictors to obtaining screening mammography. And primary care access, especially underserved communities, since they typically access the healthcare system during emergencies, there's no screening recommendations at point of care, so therefore we miss an opportunity to engage these women in self-care behaviors. This chart demonstrates a graph of, on the vertical axis, the percentage of patients who engage with screening mammography And the red line demonstrates that high primary care physician and provider engagement correlates positively with more screening mammography utilization as opposed to patients who have low primary care physician or provider engagement. So before USPSTF 2009, the American College of Radiology, ACOG, the American Academy of Family Physicians, and the American College of Physicians all recommended beginning screening at the age of 40 with screening intervals of 1 to 2 years. Post USPSTF after 2009, the American Academy of Family Physicians and the American College of Physicians changed their screening recommendations to mirror those of the USPSTF, beginning at the age of 50 and ending at the age of 74. So this is just a chart that demonstrates the number of women, the visits in which screening mammography had been recommended, and it peaked in 2008 with variability and an overall decreasing trend since 2008. This chart is a chart that demonstrates number of mammography referrals per 1,000 visits pre and post USPSTF, and they subdivided into subspecialty category as well as patient age cohort. Prior to USPSTF, there were a large numbers of mammograms being recommended per 1,000 women, and post USPSTF, you can see that there is a decline. The specialties which demonstrated the most marked decline in recommendations were general family practice as well as internal medicine. So for example, 308 mammograms per 1,000 women decreased to 249, a decrease of 18.9%. The obstetrics and gynecology practitioners also did demonstrate a decrease, however, it was much less marked. And the overall age cohort, which demonstrated a marked decrease in recommendation, was those patients greater than the age of 75, with a reduction of approximately 51.1%. So overall, screening mammography referral rates decreased by 25 to 30% overall post USPSTF recommendations in 2009. The most significant decrease in referral rates was amongst the internal medicine and family medicine physicians and providers, which are consistent with their society guidelines. And the biggest decline in referrals occurred in the population aged greater than 75. So because screening mammography has been known to have a mortality impact, any decrease in screening mammography can adversely affect mortality. And so even though white women and African American women are diagnosed with breast cancer at similar incidences, breast cancer has a disproportionate effect on African American women. Since 1990, breast cancer death rates have decreased by 26% in African American women as opposed to 40% in non-Hispanic white women. And overall, the mortality rate from breast cancer is 41% greater in African American women than non-Hispanic white women. And the question is to why? Well, we've addressed that earlier with respect to screening policy and guidelines as well as access. Additionally, tumor biology as well as social determinants of health are also primary considerations. But invitation to and participation in screening mammography is a metric that we as healthcare providers can make an impact on. So just a few notes, 23% of breast cancer diagnoses in African American women occur younger than the age of 50, as opposed to 16% in white women. The triple negative subtype represents 21% of invasive cancer in African American women and presents at a younger age. The perceived risk of breast cancer is lower in the African American community. So therefore, there is a decreased motivation to actually participate in screening mammography. And there's studies that have demonstrated on minority populations that found that working with a primary care physician and a provider to encourage screening was an effective modality in order to increase these rates of utilization. So what is the correct screening guidelines? So the American College of Radiology has stated that all women, especially African American women and those of Ashkenazi Jewish descent, should be evaluated for breast cancer risk no later than the age of 30. And so for those patients who are not at increased risk, patients shall begin screening mammography at the age of 40, no later than 45, and they shall continue as long as the woman is in good health, chooses to be screened, and tends to seek and tolerate treatment, and or the life expectancy is greater to or equal than 10 years. The following societies also agree with the aforementioned guidelines. So with respect to risk stratification, once we risk stratify, there's an opportunity for supplemental breast imaging in those patients who are deemed high risk. The imaging modalities of choice are breast MRI and breast ultrasound. Breast MRI increases cancer detection rate in high-risk patients on the order, and the sensitivity of MRI in high-risk patients is greater than 98%, with the sensitivity of mammography on the order of 37.5%. African American women are also less likely to adhere to breast MRI because, number one, they're not aware of their risk, and number two, there's lack of physician referral. Breast ultrasound is also an imaging modality which does incrementally detect more cancers in addition to mammography. However, the increased false positive rate and the lower positive predictive value decreases widespread utilization of this practice in high-risk women. So overall, with respect to mammography and MRI, if you have a genetics-based risk increase, so these are the imaging protocols for patients who have a genetic-based increased risk and they're untested first-degree relatives. Initial mammography begins at the age of 30, and they initiate screening MRI between age 25 and 30 years. For BRCA1 carriers, we initiate MRI at the age of 25 and screening mammography by the age of 30. And for BRCA2 carriers, we initiate screening MRI beginning between the ages of 25 and 30, and we initiate screening mammography by the age of 30. Screening breast imaging with respect to patients who have Hodgkin's lymphoma and they've had mantle chest radiation before the age of 30 and a dose of greater than 10 gray. Annual screening mammography is recommended between the ages of 25 or 8 years after the completion of radiation therapy, and annual MRI beginning between the ages of 25 to 30 is the recommendation. There are updated guidelines in 2018 with respect to annual breast MRI for patients who would benefit, and patients who have had a breast cancer diagnoses before the age of 50 would benefit for MRI, and patients who have breast cancers diagnosed at any age with dense breast tissue would also benefit with supplemental breast MRI screening. So in summary, annual mammography beginning at the age of 40 achieves the greatest mortality reduction for women of average risk. Risk assessment by the age of at least 30 would identify those patients who may benefit from supplemental breast imaging. African American women are more likely to be diagnosed with breast cancer under the age of 50 and have a greater proportion of aggressive tumor subtypes. Therefore, screening recommendations beginning at the age of 50 would have a significant deleterious impact on disease-specific mortality in this patient population. Primary care physicians and providers exert the most influence as it relates to adherence to screening mammography. Breast MRI is extremely sensitive for the detection of invasive ductal cancer in high-risk populations. Breast ultrasound should be performed in women with elevated risk who would qualify but are unable to undergo breast MRI.
Hello everyone, thanks for tuning in. My name is David Stein and I am a colorectal surgeon, and I'm going to be talking about screening for colorectal cancer. One of the things, as a friendly reminder, please log in to YouTube, and if you've signed up for this event, you can use the chatbot feature to ask questions or post ideas or comments as these presentations occur. So with that being said, where do we start? How does one talk about colons and cancer and screening? And I'd like to start with a fictional character, Mrs. Smith. Mrs. Smith is a 48-year-old female. She's busy. She has 3 teenage kids. She runs around. She has a part-time job, coordinating their schedule, her own schedule, crazy life. She kind of noticed over the past few years a little bit of blood in the stool. She would wipe after having a bowel movement, a little spot here, a little spot there, figured it was a hemorrhoid, ignored it. 3 months went by, 6 months went by. She showed up for her GYN appointment, routine screening, and they asked her, as they were doing the pap smear, anything else going on? And she said, you know what? I do see blood when I have a bowel movement. I said, okay, that's interesting. And in the office, they did something called a guaiac test, which is a way to measure how much blood is in the stool. That came back positive as well. And based on that, she went and got a colonoscopy. The colonoscopy that was performed was diagnostic because there was rectal bleeding, and they found in her sigmoid colon a cancer growing. So I don't want to talk about the treatment for cancer, but if we focus on Mrs. Smith, who's a 48-year-old female who is completely asymptomatic and really just sees spotting of blood, is there something that she should have been doing to ensure that she doesn't develop colon cancer, rectal cancer, or colon polyps? And that is called screening. Screening, by definition, is a test that we offer when there are no symptoms present. Most classically, and you will hear about some of these today, mammography for breast cancer, colonoscopy for colon cancer. Those are the classic screening tests we use, meaning I don't feel anything, I feel great, life is wonderful, but lo and behold, I get a test to ensure there's nothing happening in my body. And with screening tests, the whole key is the age at which we're supposed to start screening. So historically, everybody heard at age 50, I go get my colonoscopy, I get screened for colorectal cancer. But we lowered that age a few years ago. The American Cancer Society guidelines in 2018 actually lowered the age for asymptomatic screening, average risk people, to age 45. So Mrs. Smith, who at 48 was having symptoms, really should have had this done 3 years earlier. And that may have prevented a tumor from growing over those years. So what are the screening tests we can discuss? There's different kinds, and we're going to start with the least invasive, and on many levels the most awkward, to the most invasive, which, even though it's still awkward, it's less awkward because you get to go to sleep. So the least invasive test is actually looking at the stool itself. In the stool, if we have a polyp growing or a cancer growing, we start developing bleeding. And as the tumor gets bigger, the lining of the inside of the colon starts shedding blood. That hemoglobin, the breakdown of the blood product, or the actual blood itself, can get detected in stool. And there are 3 tests, or really 2 types of tests for the purposes of detecting blood and blood-related proteins. Tried and true, been around since the 50s, is a guaiac test. Guaiac is a chemical that binds with heme, iron, which is a breakdown of the red blood cell. And fecal occult blood tests, which is what we call them, you're looking for hidden blood. You don't actually see the blood, but it will pick up iron, which is a breakdown of the blood product in your stool. Now, you need, in order to do this, you can do it at home, multiple samples. So meaning you go in and you actually poop in a little package that holds it, and you poke the stool, and you're supposed to do 3 consecutive bowel movements, and that gets sent to a lab and they develop it. And if the developer shows there's iron, that means you should go ahead and get referred for further investigation, such as a colonoscopy. The next level up, also at home, similar, is called a FIT test, fecal immunohistochemical testing. A FIT test detects the actual human blood in the stool. So what happens when that occurs is same sort of thing. You don't need multiple stool samples. You move your bowels. Again, there's some mechanism to keep the stool contained. You poke it, send it to the lab. It gives you a result. Positive, you need further workup. Negative, you're okay. So if you're doing these tests every year, you should be able to determine whether or not you're at risk for a colon cancer growing. If there's no blood, the risk of colon cancer is significantly low. So what's the difference and the nuance between the two? Because fecal occult blood testing is required to look for heme, if you're eating a lot of red meat, you can make it a false positive. Certain food groups, certain other things also can make the test positive, and as I mentioned, you need multiple testing. There is a higher false positivity rate with fecal occult blood testing than there is with FIT testing. So most people are recommending FIT testing, which again is made by many different companies, and you can get it in pharmacies and in other locations. FIT testing, because it detects the actual blood, has a lower false positivity rate, but the sensitivity rates, you get a positive test when disease is present, are similar. The next level down is called multi-targeted stool DNA testing. That's a lot of words, but basically you're looking at the stool and you're sending your actual stool to a lab. They send you a little mini bucket that you put in your toilet, in your commode. You poop in there on dry ice, and the sample gets sent off to the lab. And what they're doing there is they're looking at the DNA in the actual stool. And it's crazy when you think about it, but if you have a cancer growing, we know the most common colon cancers and rectal cancers that exist. And when you have these tests, they look for the common DNA particles. And if they see that, also it's positive, you get referred for a colonoscopy where they go ahead and make sure there's nothing there. So the 3 stool-based tests that exists, again, are fecal local blood testing, about 80% sensitive at detecting, blood in the stool, FIT testing similar, and multi-targeted stool DNA testing, which is actually a little bit higher, 88%. Again, the fecal local blood test and the stool testing do have a higher false positive rate, which means that it's positive even though you don't have any disease. From there, we get into what we would call structural examinations. Okay, we looked at the stool, but now we're going to look at your colon wall structure. And there are 2 ways of doing that. Way 1 is what we affectionately call a virtual colonoscopy. And what this is imaging. Different kinds, you can do MRI-based or CAT scan-based. You still need a bowel prep. You still need to clean yourself out because the stool will show up on the imaging. But the concept is instead of putting a scope inside you, you use imaging to detect if there's any lesions or growths or cancers in the colon. So a classic virtual colonoscopy is a CAT scan-based test. You clean out as if you would a normal colonoscopy. You come into the radiology center. It's an X-ray test. They put a little catheter in your bottom in the rectum, and they inflate the colon with air. And when they do this, they distend it. So the collapsed tube goes like this, and the imaging looks for little growths inside. So if this is a normal lumen, nice and smooth, but they see something like this in the way that hasn't been cleaned out, that could be a cancer there. And if they detect that, that would be a referral for colonoscopy. And I don't know if you have been detecting the theme, but the theme is if anything else is positive, you get referred for a colonoscopy. So what is a colonoscopy? It's also considered a structural examination. And a colonoscopy is designed to go inside the colon, and the operator, someone called an endoscopist, which could be a gastroenterologist, in some places a family practitioner, a colorectal surgeon, a general surgeon. The endoscopist goes in and actually looks for him or herself at the wall of the colon. As they go in and look at this, they're detecting not just the structural views, but any growths or lesions. The biggest advantage of a colonoscopy is that at that time, they can also remove a polyp. They can biopsy a cancer. So in addition to being diagnostic, it can also be therapeutic, meaning we've diagnosed a problem, but now we can also treat it. So an early polyp that hasn't turned into a cancer yet, that can be treated. And if there is a cancer there, we know where it is and we can get the tissue biopsies, which help determine normal therapy. So the downsides of a colonoscopy, you need the prep, like a virtual colonoscopy. And often most folks want anesthesia with it. And in many places they will give sedation. So you get to take a nice nap and get your scope done and then you wake up. So on many levels it's the least awkward of all the tests because you're not messing with the stool or anything like that. But it is the most invasive in that we're putting a scope inside of you, we're giving you anesthesia, you're going to sleep, you need somebody to come with you. And you need the bowel prep as discussed. Of all the tests, colonoscopy is what we would consider the gold standard. It has the highest detection rate for polyps and cancer among all the other tests. But I think the theme here is it's much more important to get a test done than to worry about the specific test done. So if you asked me at my age, what have I did? I got myself a colonoscopy when I turned 45, even though it was a while ago. And then the next question is, well, if the colonoscopy was normal or the testing doesn't show any cancers, do I need another test? And the answer is yes. For colonoscopy, it's every 10 years to make sure that nothing new has grown in that interval. For the stool-based testing, it's for the fecal local blood and the FIT testing, that's every year. And for the multi-targeted stool DNA test, that's every 3 years. So you can pick and choose a little bit of your personal poison as to what gets you excited about making sure you're maintaining your health. Is it a stool-based test or a structural exam with a virtual colonoscopy or a colonoscopy? And based on those things, you can determine next steps. So let's rewind a minute. Why is it so important for Mrs. Smith, you remember, who at 48 had been ignoring symptoms for 3 years, to have gotten her scope? Well, let's say at 45 she went for any one of these tests and they picked up positive blood or a lesion growing. She could have had a polyp removed, because the pathway from abnormal cells to polyp growth, and the polyp that's growing turning into a cancer, can take anywhere from 3 to 10 years, depending on the studies you look at. Which means the 10-year interval makes sense, and which means that if we start screening at age 45, it's incredibly important to just be thorough, get a test done, and get yourself screened. One little piece is that's average risk. There are certain people who are at higher risk. I have a first-degree relative, a mother, a father, a sister, a brother, a son or a daughter, who has had a colon cancer. I'm in a higher risk category. And for those types of people, if you fall into that category, you should talk to your doctor about the ideal screening interval. What we discussed so far is really just about screening in asymptomatic average risk people. And the most important thing is get yourself screened. Age 45, talk to your physician, figure out the best test for you, and go get screened. Because we have really good ways of treating colon cancer, and early detection leads to very high survival. And for the inconvenience of getting a test, it's really quite silly to die of colon cancer. So with that, I thank you for your time. And again, hopefully you've been sending questions through the chat bot function, which is kind of a new world that we all live in. Have a wonderful day.
Hi, I'm Lois Kamugisha. I'm the medical oncologist who will be talking to you about lung screening today. This talk is being live streamed and I am available to answer any questions in real time. The objectives of the presentation are to identify the appropriate patient population for lung cancer screening, to examine the benefits of lung cancer screening, to examine the risks of screening, and to summarize various guidelines for lung cancer screening. Lung cancer is the leading cause of cancer-related mortality globally and in the United States. It is estimated that 1.6 million deaths globally every year will take place due to lung cancer. 5-year survival rates for lung cancer are only 19%, and most lung cancer patients present with symptoms due to advanced disease and have stage 3 or stage 4 cancer at diagnosis. Prevention rather than screening is the most effective strategy for reducing the burden of lung cancer in the long term. So promotion of smoking cessation is essential. Cigarette smoking is thought to be the cause of 85 to 90% of all lung cancer cases, and the smoking rate in the US remains high at 15%. A high percentage of lung cancer occurs in former smokers, so this group is targeted for screening as well. A number of factors suggest that lung cancer screening should be effective. A high morbidity and mortality rate, significant prevalence in the population, identified risk factors which allow targeted screening for high-risk individuals, a lengthy preclinical phase for certain types of lung cancer, and also evidence that therapy is more effective in early stage disease. The potential of screening to detect early cancers may both increase the overall cure rate and allow more limited surgical resection to achieve cure in these patients. However, screening must be performed in the context of a multidisciplinary program to ensure that guidelines are followed closely and results are properly interpreted, followed up, and that disease, when detected, is managed appropriately. The success of lung cancer screening is best assessed with disease-specific mortality and overall mortality rates. Many studies have revealed that chest X-ray and sputum cytology are not useful in reducing lung cancer mortality rates. In 2020, low-dose CT scanning is used for screening programs. A low-dose CT refers to a non-contrast study obtained with a multi-detector CT scanner during a single maximal inspiratory breath hold with a scanning time under 25 seconds. And the advantage of this is that the radiation dose exposure is about 10 to 30% that of a standard dose diagnostic chest CT examination. There are two very important trials which have indicated the importance of low-dose CT scanning in its role in reducing lung cancer mortality. The National Lung Screening Trial was a randomized trial enrolling patients between August 2002 and April 2004. It compared annual screening by low-dose CT scanning with chest X-ray for 3 years in more than 53,000 high-risk persons at 33 United States medical centers. Participants were men and women 55 to 74 years old with a history of at least 30 pack years of smoking. The patients included current smokers and also those who had discontinued smoking within 15 years of enrollment. The study demonstrated that screening reduced mortality in a high-risk population compared with screening by chest X-ray. And this relative mortality reduction was 20% with a 6.7% relative reduction in all-cause mortality. So again, at the top, you can see the cumulative number of lung cancer cases being higher in the population screened with low-dose CT versus chest X-ray. And then lower down, you can actually see the number of lung cancer deaths being significantly higher in the chest X-ray group. However, in this study, for those undergoing at least one screen, the number needed to screen with low-dose CT to prevent one lung cancer death was 320. The second trial was based in Europe, and that's the Nelson trial. So this was a randomized low-dose CT-based lung cancer trial. It included just under 16,000 patients, approximately 84% male, current or former smokers in Belgium and the Netherlands. So it compared low-dose CT with no screening at all, which of course was an important difference compared to the National Lung Screening Trial. The intervals also were different. There was a baseline study and subsequent screenings at years 1, 3, and 5.5. The study was powered to detect a 25% decrease in lung cancer mortality after 10 years, as well as the effects of screening on quality of life, smoking cessation, and estimated cost effectiveness. Unlike other screening studies, 5-year lung cancer survivors, a group at very high risk of developing a new lung cancer, were eligible for enrollment. At 10 years, the lung cancer mortality for men was reduced by 24%, and for the smaller group of screened women, there was a 48% reduction in mortality at 9 years compared with unscreened women. So we've just discussed the clear benefits of lung cancer screening in terms of its impact on mortality and morbidity, but there are harms associated with screening. So there are consequences of evaluating abnormal findings. So when these findings are evaluated, the interventions can include needle biopsy and surgery with associated morbidity and very rarely mortality. However, in most situations, the follow-up consists of various imaging procedures, and only 11% of patients with a positive finding in the NLST trial actually underwent an invasive procedure. Many screened patients also have incidental findings such as COPD or coronary calcifications, and these may or may not require follow-up testing, but they do often cause patient worry and also add to the cost of screening. Further harms include radiation exposure. Cumulative radiation does need to be discussed with the patient. It was estimated after a secondary analysis of an LDCT screening program that for every 108 lung cancers discovered by screening, one major cancer would be induced by the radiation exposure. Patient distress has been studied, but has been found to generally be short-term. We have no data indicating that there is increased anxiety long-term with screening. Overdiagnosis is also a problem, since some cancers identified at screening would never have caused morbidity or mortality for the patient. Observational studies have estimated that the extent of overdiagnosis can vary between 13 and 27%. So there are a number of questions which remain regarding screening. What is the optimal screening frequency and duration? Different trials did use different screening frequencies and durations. The appropriate population targets also remain up for discussion. It is known that with a high-risk population, the benefit to screening and the risk of screening would move in a positive direction. How do we define criteria for a positive finding on imaging? And how do we generate diagnostic follow-up protocols that minimize evaluations of false positive findings? There is also research ongoing in risk prediction models. So trials have selected participants who are considered at high risk based on smoking history, personal history, family history, and exposure to carcinogens. However, the benefits from screening could be improved if we could precisely identify a very high-risk population. Regarding older age, in the NLST trial, only 25% of participants were greater than or equal to 65 years of age, and none were older than 75. An analysis did reveal that patients who were older were more likely to have false positive screens, but screening revealed higher prevalence and a higher positive predictive value for lung cancer. Women were underrepresented in both of the large randomized lung cancer screening studies. However, there is evidence suggesting that lung cancer screening may be more effective in women than men. Decisions regarding implementation of a lung cancer screening program should in part be based upon a cost-effectiveness analysis of the screening program. One analysis revealed a cost ranging from $126,000 to $269,000 US per quality adjusted life year. However, another model done after the completion of the National Lung Screening Trial estimated that the cost would be $81,000 per quality adjusted life year. In the US, it's thought to be acceptable once we reach a threshold of $100,000 US per quality adjusted life year. So the model did note that estimates do vary depending on the subgroup, and the screening is thought to be more cost-effective in women and in groups with a higher risk of lung cancer. Finally, recommendations by expert groups. So with the American Association for Thoracic Surgery, their guidelines extend the age for screening going from age 55 to 79 years for high-risk individuals, and they also advise initiating screening at age 50 for those with a cumulative risk of 5% or greater of lung cancer over the next 5 years. Many groups issue guidelines advising patient counseling on the risks and benefits of screening, the development of a registry to collect data on follow-up testing, smoking behavior, radiation exposure, and patient experience, the development of quality metrics for CT interpretation, similar to quality control measures for mammography, and also all of these groups emphasize the importance of smoking cessation. I will spend some time on the guidelines from the National Comprehensive Cancer Network. These guidelines, again, recommend discussion of screening with annual low-dose CT scan for those at high risk. They recommend no routine screening for moderate or low-risk individuals. High-risk individuals were defined as age 55 to 74 years with a greater than or equal to 30-pack-year history of smoking, and if no longer smoking, smoking cessation within 15 years. There's another group, age greater than or equal to 50, with a 20-pack-year history of smoking and one additional risk factor. So this additional risk factor may be a personal history of lung cancer, a family history of lung cancer, history of radiation to the thorax, pulmonary fibrosis, COPD, etc. Notice secondhand smoke exposure is not considered an additional risk factor. Although the guidelines note that the duration of screening is uncertain, they advise a minimum of 3 scans and suggest that CT scans continue until the patient is no longer eligible for definitive treatment. The guidelines emphasize that lung cancer screening should be done within the context of a multidisciplinary program. In 2020, the NCCN has extended the age range to 77 years. So that just happened this year. So rather than 74 years as the cutoff, they are now recommending up to 77 years. As for the U.S. Preventive Services Task Force, they recommend annual low-dose CT scan for high-risk adults 55 to 80 years old with a 30-pack-year smoking history and current smoker or having quit within the past 15 years. They do recommend discontinuation once the individual has not smoked for 15 years or has a limited life expectancy. So in summary, for patients in good health who are thought to have a risk for lung cancer at least as great as those in the National Lung Screening Trial and who have access to centers with capabilities similar to those in the trial, and for whom the cost of screening is not an issue, you should proceed with annual screening with low-dose helical CT. High-risk criteria for participation are as outlined here, and consistent with modeling studies, you should consider screening for high-risk patients in good health up to age 80. For former smokers, annual screening should continue until 15 years has elapsed from the date of smoking cessation. Thank you for your attention.
Welcome to our Cancer Care Symposium. I've been asked to discuss prostate cancer screening, which will primarily focus on the evolving role of PSA. Prostate cancer is the second most frequently diagnosed cancer and the third most common cause of cancer death in U.S. men. There are approximately 192,000 cases as of 2018 a year. U.S. men have a 12% lifetime risk of developing prostate cancer and a 2.4% risk of dying of the disease. There has been declining mortality in prostate cancer from 1992 to 2016. The reasons are not entirely clear, but likely have to do with both PSA as well as improvements in treatment. The objective for this particular talk are as follows. 1, define the prostate-specific antigen, parentheses, PSA, actually is and describe the history of its discovery as a use as a biomarker. Learn the application of PSA and its derivatives in predicting prostate cancer. And finally, recognize and interpret some national guidelines for prostate cancer, including the National Collaborative Cancer Center Network, the United States Preventative Task Force, and the American Cancer Society guidelines. What is prostate-specific antigen? There's a picture of it in a 3-dimensional diagram from days as a chem major. but it is a glycoprotein protease found in high concentrations in the male ejaculate. Its early discovery was pioneered by forensic scientists looking for a tool to use in rape cases. It is in the ejaculate and independent of semen, so it can be used in azoospermic males as well as in men who've undergone vasectomies. Contemporaneously, it was also being looked at as a novel birth control agent target, as the role of PSA in the ejaculate is to liquefy coagulum such that the sperm are free to swim and implant the egg. It does this by its protease activity, which is activated by a lowered pH in the vaginal environment. Zinc also plays a role in its regulation. It wasn't until nearly 2 decades after its discovery that it was first reported in the New England Journal of Medicine its use as a biomarker in prostate cancer. This sentinel article, published in the New England Journal of Medicine in 1987, presents the data of men that they reviewed with prostate cancer. It evaluated both PSAs as well as serum prostatic acid phosphatase, which at the time was the gold standard for monitoring prostate cancer. In men with a known diagnosis of prostate cancer, the levels of PAP and PSA were evaluated and reviewed. PSA was found to be elevated in 122 of 127 newly diagnosed prostate cancer patients. 7 of those 12 had very early stage disease. PAP, the previous gold standard, was only elevated in 57 of 127 patients. In addition, PSA seemed to correlate well with both clinical stage as well as the amount of tumor. PSA was seen to decline to undetectable after successful surgery with an in vivo half-life of 2.5 days, whereas prostatic acid phosphatase, the previous standard, did not become 0 after surgery. After this sentinel study, PSA started to be evaluated and used for both monitoring and ultimately screening for prostate cancer. So you might ask, how does this glycoprotein produced in the prostate, measured in the blood, help in determining someone's risk for prostate cancer? Well, PSA is normally found in high concentrations in the prostate and ejaculate. In the healthy prostate, the integrity of the prostate gland itself keeps most of the PSA in the gland. Only small amounts of the glycoproteins end up in the blood. These small amounts are normal. Conditions which interrupt the gland's integrity can lead to high leakage of the PSA in the blood. Conditions such as cancer and benign conditions such as infection or benign prostatic hypertrophy can elevate the levels in the blood. Some very undifferentiated tumors or cancers fail to produce PSA. As we have learned, the PSA is normally found in low levels in blood, and what is meant by normal can vary. It varies by several factors, the most important being age, but also to a lesser extent race. Normal PSA ranges from 0 to 2.5 in the 4th decade and increases to an upper normal of 6.5 in the 7th decade. It seems that race somewhat plays a role in that normal numbers are lower for Asian Americans, intermediate for Caucasian, and somewhat higher for African Americans. However, it's not a huge difference, but African Americans' normal range limit tends to be about a point higher. As PSA adaptation has increased, derivatives of the value have become helpful in predicting prostate cancer detection. The 2 derivatives that you will see most often reported are Psa Velocity and free PSA. Psa Velocity is merely the rise of baseline PSA over time. A PSA short doubling time measured in months is associated with an increased risk of cancer detection. Free PSA, that percentage of total PSA which is not bound to protein in the blood, is known as free PSA. PSA which is bound to protein in the blood is more likely to be associated with cancer than that, and the ratio is high. This is particularly helpful in PSA reading, which is only modestly elevated or higher than normal, to help determine the likelihood of cancer. This slide shows that free PSA can be particularly helpful in younger men, as seen in this slide. The probability of a very low free PSA in different age groups is most pronounced as a predictive measure in younger men, as can be seen. Finding a more treatable cancer in younger patients obviously will yield the largest benefit in screening tool and its free PSA use, while controversial as a screening tool is increasing. Which brings us to the national guideline standards and review of the current screening recommendations for PSA and prostate cancer. All of the guidelines that we discuss are similar. However, I think the Ncc and Guidelines provide widespread utility and that is developed by an expert collaborative group that utilizes a multidisciplinary approach of cancer specialists, including surgeons, medical oncologists, and radiation oncologists in developing these guidelines. I wanted to show you this preface in the Ncc and Guidelines before we actually discuss them. I think it's very important. The Ncc and Guidelines recognizes that this disease represents a wide spectrum of illnesses and that while PSA may be helpful, it has the limitations of detecting malignancies versus benign etiologies, that screening might actually not clinically useful in all cases, and it can miss cancers that don't produce PSA. Screening PSA elevations may also lead to unnecessary morbidity and biopsies such as pain, bleeding, and infections. PSA can also discover cancers that aren't clinically significant and lead to unnecessary treatment. This is the actual guideline. It's somewhat busy, but it's not very complicated if you actually look at it. It emphasizes a shared decision-making with patients regarding PSA screening, which should include a history and physical, history of cancer in the family, especially prostate cancer, any known germline mutation, such as BRCA1 and BRCA2 in the family, race, patient's medication history, as some medications such as finasteride may actually lower the PSA. Based upon these findings, the patient and the physician should have a discussion about how they wish to proceed. Once it is determined that the patient and the physician agree to participate in a PSA screening program, it is strongly recommended that a digital rectal examination be part of that as a baseline. However, DRE as a standalone test has not been found to be particularly helpful in detecting prostate cancer. The guideline is broken down into risk groups based on age, race, and other risk factors. In men aged 40 to 75, depending upon race, or those at high risk based upon germline mutation, the guideline is shown PSA less than 1, repeat every 1 to 4 years, repeat every 2 to 3 years if PSA is greater than 3 or suspicious. DRE, repeat if suspicious findings. Further evaluation include referral to a urologist. In asymptomatic men with no known risk factors or over 75, PSA is not recommended. If PSA screening has been part of their health maintenance at a younger age, then guidelines could continue at 4-year intervals. The U.S. Preventive Task Force recommendation on PSA created quite a bit of controversy as they did not recommend PSA screening. However, in the population of men that they thought should be considered, it was 15 years later than that of the Ncc and Guidelines at 55. A discussion regarding the issue should be done with the patient and physician. This grade was a grade C, indicating there was some controversy and not a lot of great data to indicate that PSA screenings should be done. In men over 70, it was recommended that it not be performed. You may ask, why is this? Here is 1,000 men that were studied by the USPTF to come up with the recommendations. Of 1,000 men aged 55 to 69 that were screened, 240 of them would have positive PSA results. Many of them would have false positive results, elevated PSA but no cancer. Most of these men would get a biopsy with potential side effects of the biopsy. Ultimately, less than half of the men with elevated PSA would actually have prostate cancer, 100 of the 1,000. Of the 100 that had prostate cancer, 80 of them would ultimately elect to have treatment either with surgery or radiation. And of those 80 patients that would be treated, 50 would have of the 80 would have erectile dysfunction, and 15 of the 80 would have urinary incontinence. The final outcome of those 1,000 screened individuals, 1.3% of 1.3 of 1,000 screened men would avoid a cancer death. 3 of 1,000 would avoid cancer metastasis, and 5 of 1,000 would die of prostate cancer despite screening. So the actual benefit is 1.3 per 1,000. The final guideline that I will discuss is that of the American Cancer Society. It is the least complex, but does discuss the same issues that the other guidelines review. Recommendations for men age 50 who are at average risk and expect to live at least 10 years to have a PSA screening. Men at age 45 or younger who are at high risk beginning PSA screening at that age, and men age 40 who have a first-degree relative or have a germline mutation to start PSA screenings. Men who choose to have screenings should have it every 2 years initially if the PSA is below 2.5, and annually if it's over 2.5. Stop screening if life expectancy is less than 10 years. There are other guidelines that include the American Urological Association, the American Association of Family Practitioners, and the AUA guidelines, all similar to the Ncc and Guidelines in its complexity and multifaceted discussion. The American Academy of Family Physicians does not recommend PSA screenings at all. Patient-centered tools to discuss this with patients are available from the American Cancer Society, ASCO, and the Mayo Clinic, available free for you to use on their website. In summary, PSA screening guideline conclusions: not one size fits all. There are varying risks associated with prostate cancer, screening based upon age, both personal and family history and race. There are risks of screening, including risk of biopsy, risk of unnecessary treatments and injury, and worry. It is not a perfect test, and normal PSA can still miss cancers and, unfortunately, often very aggressive cancers. Hopefully, with time, there will be improvements in either this biomarker or other biomarkers for screening of prostate cancer.
Well, thank you for sticking around for our symposium today. I hope you enjoyed the first session. Screening is very important and it keeps changing. Not too many things change, but that's really important to keep on track with this and know what's the latest on this. New technology is making screenings more efficient and more effective, hopefully. The next session, this session, is quite interesting, I find. The first part, I'll be speaking about the effect of COVID on cancer care. The effects of COVID on cancer care have been dramatic, and it's a big subject. I'll try to cover it within less than half an hour. But we also have Dr. Chris Kearney, who is in charge of MedStar Palliative Care Network. Dr. Kearney is an outstanding speaker on the subject of palliative care, and I thought this would be an interesting presentation for you to attend. And Dr. Mohebtash will close the session with a presentation on monoclonal gammopathy. It's not a very popular subject, but a lot of doctors have requested information about this subject. So this meets the needs for our community. And remember, if you complete the survey, you'll get your 2.75 hours of credit for your CME. I will dig into my presentation, and the title is The Impact of COVID-19 on Cancer Care. In this session, I will try to discuss the impact of the pandemic on cancer care, focusing on delays of treatment. I will introduce alternative treatment strategies and options, and I'll try to create a framework for understanding the prioritization of care. And I'll have a small introduction on telehealth. This is exciting. I think telehealth is going to be very important in the future of medical practice. I have no relevant disclosures on this subject. The CDC has highlighted the delays in cancer care. This is not only the CDC, actually, the National Health Service in the UK, and reports from all over the world indicating delays in cancer treatment, which could be costly for patients and could increase mortality and costly for society, obviously. The CDC reported that 4 in 10 US adults avoid medical care because of concern about the COVID-19 epidemic. Unfortunately, people with disabilities and people with 2 or more underlying conditions are the ones that are affected the most, and these are the ones that cannot afford to delay care. So the CDC goes ahead and encourages people to go back to treatment. If you're sick, seek treatment. And I'll go into some details about that. And they throw a dig for telehealth, saying this may help deal with this issue. I wanted to show that this is a universal experience. Dr. Papowski from University of Illinois surveyed 609 breast cancer survivors, and she reported almost the same numbers as the CDC. 44% reported delays in all aspects of care, diagnosis, surgery, radiation, chemotherapy, and so on. That's a big number, and what's as disturbing is that younger responders reported higher incidence of delays, which is also quite concerning. In our environment, you know, our breast center here at MedStar Good Samaritan Hospital covers both this hospital and the MedStar Uni Memorial Hospital community. We actually are now covering a little bit of the Harbor Hospital as well. We've seen the volume reductions in screening, surgeries, medical and radiation oncology visits. Actually, in the beginning, we have a complete shutdown of all screening activity, cancellation of elective surgical procedures. And it took a long time to start recovering. We started opening up a little bit and slowly and carefully in July, August, and now we're up to about 80% of our baseline volumes. We're seeing delays in the diagnosis that were rarely seen before. We used to see them, but very rarely. Our network, MedStar Health Cancer Network, have had 2 groups actually looking and meeting and creating solutions to deal with these issues. We have the MedStar-wide group, and we have our MedStar North group dealing with the issues of mitigating the effects of the epidemic. These were led by Dr. Arifai from Georgetown and Dr. Aboulafia here in Baltimore. An example of patient delays is this 61-year-old lady who I saw last week, and I did a biopsy last week. This is a large fungating tumor that's been growing since March, but she was afraid to come to seek help. And I did the biopsy in the office showing a ER/PR negative disease, HER2 positive disease. The ultrasound on the right side, they couldn't capture the whole tumor with the ultrasound, but shows how vascular the tumor is. These tumors are pretty aggressive. These patients respond extremely well to preoperative chemotherapy. The standard protocol for them noted below may achieve 50% complete pathologic response, especially in the ER/PR negative HER2 positive disease. And that's why these patients have to come and have to be treated. Otherwise, we see this type of problems. How do we measure, how do we balance whether the danger from COVID is higher or the danger of the cancer? For example, if you have a low-grade prostate cancer, it probably could wait a significant period of time before being treated. So it'll be wise for patients to wait. There, the balance is for delaying the cancer treatment. An interesting tool I ran into was developed by University of Michigan. This is the link for it if you're interested to check it and use it. The link allows you, it's free online, and you could estimate what's the risk of COVID versus the risk of delay of treatment. And this way, people could make informed decisions. I have to warn you that the risks of COVID might vary with time and location. So I wouldn't count on that 100%, but it's additional information that one could use to calculate the balance of risk that we're talking about. We have also received a lot of guidance on how to deal with this epidemic. I'm listing here only a small number of societies, and they really have been very progressive and moving forward with this. We have the American College of Surgeons have had good leadership role. ASCO, the American Society of Clinical Oncology, the Society of Surgical Oncology, the American Society of Breast Surgeons, European Society of Medical Oncology, and U.S. Colorectal Cancer Alliance. Many of them have worked together to give us guidance on how to deal with different cancer sites. I can't cover all these cancer sites, but I'll give you a taste going through breast cancer. For breast cancer, the guidance is largely agreed upon by the American College of Surgeons, the ASBS, and SSO. For example, they say these patients should not delay treatment. These are patients who have completed preoperative chemotherapy for triple negative or HER2 positive disease. These are patients like the patients I showed you who received the chemotherapy now. The tumor is suppressed and they're ready for surgery. These patients should be operated in a reasonable period of time. Similarly, patients who progress on preoperative chemotherapy, we don't see that very often, but if a patient is getting the chemotherapy and the tumor is not shrinking, these are patients who should be expedited. Inflammatory breast cancer is another situation where we move on with surgery after completing preoperative chemotherapy. And these are the type of things, the guidance that really helps us make decisions. There are, however, a lot of patients who can be delayed. For example, patients who have DCIS and are ER/PR positive. DCIS may take years to turn into a cancer, maybe at most months. These patients could be treated with hormonal therapy and treatment could be delayed, as well as patients, especially with small ER/PR positive HER2 negative disease. These patients almost always respond or stabilize on hormonal therapy, and there's probably no loss of survivor if you just give them a few months of hormonal therapy before the surgery. Other things that should be delayed are atypical or high-risk lesions where the chances of malignancy is small, and these could be small tumors anyway, or reconstructions, prophylactic surgery, and other benign disease. So I'm going to give you examples of where does this work. This is another patient I saw last week. This is a 53-year-old who felt a mass in her breast about a year ago. She thought it's a bruise because she felt it when she hit against a wall or something, which is often what happens. Patients think it's a bruise, but that's when they notice the mass. She had ignored this tumor till January, February, and she thought it'll go away. It did not, so she decided to seek care, but then the epidemic care, and she did not show up till October. A needle biopsy of that showed a nasty tumor, an aggressive tumor. These are triple negative cancers who do not respond to, that don't respond to hormonal therapy. They respond only to chemotherapy, and they need surgery, and she needs radiation. You could see the tumor on the left side, and you could see how it occupies much of the breast on her mammogram. So that patient, if she came in February, she probably would be treated. If she came in March, you start thinking, well, we need to treat her. If she came at the height of the epidemic in New York City or Brooklyn or something, then it'd be a different ball game. So this is, the American College of Surgeons came up with this classification of the phases of the pandemic to help people make these decisions. So they have the acute phases. They've put them into 3 phases, phase 1, 2, and 3. Phase 1 is the beginning of the epidemic when resources are still available and when you would treat patients at that phase, because you're predicting that things are going to go bad, but that might take weeks for that. So we kind of take care of these patients right on the spot. Phase 2, the resources are becoming tight, and you only treat patients who will be harmed if they wait more than 3 weeks. Phase 3 is in the height of the epidemic where you only deal with emergencies. So this is the kind of logic you need to use. Then you get into the phases of recovery, which we went through at our organization in opening up resources, whether it's diagnostic, screening, and operating room resources. These are examples of patients that we treated during the epidemic. The first patient on the left side is an ER-positive tumor. As you can see, if you look at the screen, this is less than 1 centimeter in size. There's no reason to operate on that patient in April or May. This patient received hormonal therapy for 4 months, and recently we did a lumpectomy with sentinel lymph node biopsy and intraoperative radiation therapy for this patient, and she did well. This is the logic that we need to use. One thing, I'm going to throw a dig for intraoperative radiation therapy. We've done a large number of patients with excellent results, and for this patient will avoid 20 or 30 visits to the radiation center and the hospital. It's not applicable for everybody, but this is a good patient for that. The patient on the right is a patient with a small DCIS. She's 59 years old. Her tumor is ER/PR positive. Again, hormonal therapy for a few months, then surgery. Colorectal malignancy is another place where tough decisions have to be made. So if you have nearly obstructing colorectal cancers, these patients have to be treated. Might not be that they have to be treated within the next week, but they can't wait a month or 2 months. They come back to the emergency room obstructed with high mortality. That's not good. There are patients who are constantly bleeding, requiring transfusion, patients who are symptomatic, rectal cancers where neoadjuvant chemoradiation did not do well, they didn't respond well to that. Patients where there's a concern about the local perforation where you'll end up with an emergency operation, not good. So the Alliance for Colorectal Surgery have recommended that these patients be expedited However, patients with malignant polyps or prophylactic indications for surgery or large benign appearing asymptomatic polyps and so on, these could wait. For lung cancer, which is another common cancer we treat, there's an international consensus group that provided guidance. I don't know much about lung cancer, so I'm not going to delve into the details of that. So at the end of the day, therefore, what one has to do is really balance the risks and benefits, and to the best of their judgment and guidance from organization and through a multidisciplinary discussion, which is what we do for all our cancer patients, and make the right decisions for the patients and for the staff. You don't expose your staff and the operating room staff and anesthesia and the hospital staff to patients if it can wait till the epidemic is subsided. This brings us to the role of telehealth in all of this. Telehealth has been very helpful for many of us. I thought this is interesting. You can't list your iPhone as your primary care physician. Introducing telehealth here. What's key about the role of telemedicine in our practice is picking the right patient with the right use case with the right diagnosis. You can't do a gynecologic exam through telehealth. You can't operate on patients through telehealth, but you can check on their compliance with their medications. You could check on if their incisions post-operatively. So you have to be selective where you use telemedicine and telehealth. What's another key factor, once you determine which patients are appropriate for a telehealth visit, you have to prepare for the visits. To prepare for the visits, the provider has to review the record. They have to know what they're talking about, the same way we review a record before we walk into a patient's room. You define what information should be collected before you encounter the patients, such as their chief complaint, past history, social history, allergies, medications. This is often done by our help in the office, whether it's medical assistants or otherwise. Collecting that information and us being aware of it before we see the patient makes the encounter much more useful. And then you get ready for the visit. There are some etiquettes for virtual visits, obviously. You have to dress appropriately. You can't be unprofessional. You have to be on time. The patients, from my experience, when you tell them you're going to call them or you're going to invite them, they're ready, they're waiting, and they get anxious if you keep them waiting. If there are other people with you, introduce them. I tend to use a chaperone in most cases. And I think that's important, especially people could be talking about private things or maybe showing you an incision in private areas and so on. I think it's important to have a chaperone, if at all possible. You need a quiet location, appropriate background, and make sure your technology works before you invite them, so internet connections. And you have speak up, no mumbling, and you mute your microphone if you're talking to the staff next door, if there's a little noise outside. Some physical exam findings could be obviously ascertained by telehealth, obviously, so you can ask the patients where the pain, to touch parts of their abdomen, especially in low-risk situations. And another aspect of telehealth, it could be a good team effort, like a multidisciplinary, or other trainees, physicians, residents, nurses could be on the meetings. Zoom meetings allow you that. I think that's an additional advantage to the face-to-face encounter. At the end of the day, when you finish your encounter with the patient, it's important to plan and wrap it up. You have to reach a conclusion with instructions to the patients. Review the recommendations clearly with the patients, recap suspected diagnosis, outline a treatment plan, send handouts, delegate next steps to somebody. Teresa will schedule you for a mammogram. Deborah will call you in 2 weeks to check on you, so on, so that there's a closure to that encounter. There are many telehealth options. And when surveyed, physicians felt that the most important thing about telehealth is the ease of use by patients. That's the biggest barrier. So whoever designs and uses a telehealth platform, make sure it's easy for the patients. That the next thing that's important for them is the reliability. Then it's ease of use by provider. That only ranked at 30%, because I guess you count on the providers being able to do this. And only 19% really cared about the security as much as organizations do. These are virtual visit platforms that are available. Some of them you pay for them. Some of them I think are almost free. But this just, I'm putting this so that you know that there are options for providers to look at. The thing that brought telehealth into the picture is changes in the law. Medicare allows, Medicare will pay for these telehealth visits for also all kinds of providers, including physicians, nurse practitioners, PAs, clinical psychologists, licensed clinical social workers, and so on. So that brought telehealth alive for everybody. The other things that made telehealth easier to adopt is some relaxation of the HIPAA rules. The government said we're not going to enforce HIPAA rules during the pandemic, which really helped people use some of the FaceTime and other non-secure modalities. Also waiving federal licensing regulations. This enabled physicians to treat patients in different states for via telehealth, and also payment parity, which is really important. Finally, I'm not going to delve into this too much, but we have 3 types of telehealth visits. The telehealth visit, which is audio and video. Then there's the telephone visit, which is also paid for, which is audio only. And the e-visit, which is online messaging, but these have to be initiated by the patient. The impact of telehealth on the way we deliver care has been dramatic. The green is face-to-face encounters. Throughout the world, the face-to-face encounters became the minority of encounters during the pandemic, except in China. So that's interesting, and I don't know where it's going to settle down eventually. Having said all this about telehealth and its safety and efficiency, don't forget that face-to-face encounters with mitigation could be very safe. This is an interesting study from Massachusetts, 4 Harvard hospitals, 3,000 deliveries, out of which 111 patients tested positive when they went into labor. That's about 3.7% of that cohort. They matched each one of these patients with 5 controls, and then from the electronic medical record calculated how many in-person encounters that each group has. The number of in-person encounters was 3.1 encounters for the positive patients and 3.3 for the patients who tested negative. This just suggests that there might not be a huge danger from face-to-face or in-person encounters. Does not answer the question, but challenges the concept that's dangerous to have in-person encounters. Another thing that really highlights the importance of telehealth in the future is what the Cleveland Clinic Foundation calls side effects of the in-person visits. Lost wages, death from accidents, paying for gas, tolls, child care, so on and so forth. So I think a lot of people are going to find telehealth convenient in the future, and I think it's going to stick around. The key is answering the questions: who are the best patients that you can apply telehealth to? So I'll finish here and conclude that delays of cancer screening and treatment are dangerous and costly. Prioritizing diagnostic and treatment intervention is based on a balance of cancer risk versus COVID-19 risk, and we have increasing number of tools to help us with that. Systems devised to manage different epidemic phases are important so that we know what to do at different phases, because it's a fluid situation. Mitigation of risk, very important. Masks, hygiene, distancing. We should apply these in a very disciplined way. And a systematic approach to telehealth implementation is key to its success. And I think telehealth is here to stay and would likely improve care and reduce cost if properly implemented. Thank you for listening, and happy to entertain any questions.
Good afternoon. Thank you for inviting me to talk to the Cancer Symposium this afternoon. I'm Dr. Christopher Kearney. I'm the Palliative Care Director at MedStar Franklin Square Hospital and the former Director for MedStar Health Palliative Care. I would look forward to the opportunity to talk this afternoon, and if you're on YouTube, please log in and submit questions in the chat box, and we will do our best to answer in real time. The topic, unsurprisingly, palliative care in a comprehensive cancer program is close to my heart, and I'm looking forward to talking about it. We hope during the talk this afternoon at least to mention what Dr. Farha has asked me to talk about, which is the indications for palliative care consultation, timing, and possibly benefits for palliative care in general oncology care. So going back in history about 8 years to 2012, ASCO did a position statement or clinical practice guidelines which said that integration of palliative care in standard oncology would be recommended for all patients with advanced stage cancer, and it would be provided ideally by a multidisciplinary team. They suggested that ideally, again, that care would be provided within a reasonably short period of time of these diagnoses of advanced cancer. And I would comment on that early on to say that any of us, if we ourselves were presented with a advanced cancer diagnosis, the moment that happened to us, the world would change. Everything about us would change. And it wouldn't just be the tumor or the possible treatment programs. It would be all the other human factors which come under attack, so to speak, and therefore possibly the justification for a broader look at our care in comprehensive cancer program. Finally, there is evidence now growing in the early studies. The TEML study that most of us are familiar with compared metastatic non-small cell lung cancers with usual care versus usual care plus palliative care. And the study showed that there were some benefits in the more psychosocial range, less depression or anxiety. But the thing that caught everyone's attention was that the patients who received the palliative care plus usual care lived longer, in a range of 3 months longer than the cohort in usual care. So that was, in some ways, sort of like a new drug. So why, though, do I have to tell you, or why do we have to talk about this topic, one that is probably very familiar to most of you already? Oncologists provide palliative care and have since the beginning. It's part of routine care. That your patients do not spend all their time dying of their disease. Most of them are living well with their disease. So why does palliative care have to be part of the format? This is a true sense from most patients that they prefer their doctors to be optimistic. They like to hear about hope. They don't like negativity so much. And palliative care in some ways sounds negative to our patients and to their families. And even among oncology colleagues, it has a negative connotation. In some places, they've even changed the name from palliative care to supportive care services, with reasonable thinking behind that. There is this argument as well that these discussions are quite time-consuming. Many of you are in busy practices where your time is tight, and you would worry about dropping down a rabbit hole with long conversations about issues, many of which are not actually directly medical or oncological. So reasons why we don't really need to pursue this dialogue about palliative care in your world. However, these are the other issues that you're also very well aware of. So your patients are often seriously ill, at least at time during their treatment program. They have long clinical courses often, and at least part of the time there can be a significant symptom burden. They can have significant psychosocial symptoms. They certainly have financial issues often, and of course even spiritual issues, all of which impact how they are doing, how they feel, how they are cared for. The tenets of oncology care is that they have to be able to tolerate your therapy to start with, or it's a no-go. But the tumor also then has to respond to your treatment plan to get ongoing success. The other question that you're all familiar with, of course, is what their functional status was before they started out in your care, what their comorbidities are. And then this other issue of all of those issues above, financial, spiritual, psychosocial, will play a factor in their ability to adhere, their ability to stay with the program and be successful. So all of these are part of your world every day with these patients. A lot to ask from one practitioner. So this multidisciplinary approach has been advocated for years in oncology. This statement actually was heisted from Tom Finucane down at Bayview, and still one of my favorites. So how gravely ill becomes dying and why it's difficult. And this statement I still use regularly: the widespread and deeply held desire not to be dead is actually still universal among our patients almost at any age and at any stage of their disease. So in my work, I recognize that. I know most people still want to stick around, whatever chance they may have. Our second challenge is our, maybe not inability, but our not precise ability to foretell what's going to happen in the future in terms of prognosis, and we'll talk about that more in a little bit. And then if another quote stolen from Finucane: if death is the only choice, many patients who have only a small amount of hope will pay a pretty high price to continue that struggle, and you see that regularly in your practices. Similarly, why is this work so complicated for you and for your palliative care colleagues? The concept of short versus long-term prognosis. In general, we aren't so bad in longer-term prognosis. Most of you have a very good idea, likely, of how long your patients may live in ranges of years. However, when you get closer to the short term, it becomes much more difficult and much less reliable in cancer, as with many other diseases. So it hampers our ability to accurately guide our patients in some ways. We are also, as our patients progress in their illness, for many reasons, often relying on their designated surrogate decision makers, and those are always part of the healthcare of our cancer patients and our palliative patients. They may or may not, however, have a very accurate view of what the patient themselves would want or understands. There's plenty of evidence that in some studies, at least, the surrogate is not right many more times than the flip of a coin in terms of knowing what their mother or their father or their brother really wants. given the overall circumstances. The world we live in has expectations. Our organizations and your organization certainly has expectations of quality metrics and guidelines about what care you provide to your seriously ill patients. That this is a last point that we'll come back to a little bit. As you probably know, most of palliative work in the United States still remains within the hospital confines. There is a strong movement and much energy into moving palliative care out into the community, but at this point we are still fairly hospital bound, and as you will see, there are many patients there that are your patients as well. The surprise question has been around for some years. This was Joanne Lynn down at George Washington saying, giving someone an idea of who might need palliative care. And she didn't say, do you know that your patient may only have 6 months or less to live? But rather, would you be surprised if the patient you're caring for now becomes seriously ill or dies in the next 6 months? If the answer is no, then we all, I think, are responsible to consider our duties caring for a patient whose time may be short. What is the totality of care they need that would be involved in that time frame? It opens the door, in my mind, to be for us to think more widely about our patients' care. Hospice, as you know, requires someone to say they may only live 6 months, and it's a limiting factor. But for palliative, I think it allows you to think more broadly about the patient's needs as you're caring for them on their journey. So no palliative care talk in the world was ever given without showing this diagram. Usual care, so that this is the former, you make a diagnosis of advanced cancer, stage 4, 3 or 4 cancer. You will treat until there is no further benefit seen, and then there's nothing left to do. You would turn them over to your palliative or hospice colleagues. A better version in almost everyone's mind now would look more like this, where even at diagnosis, there will be palliative needs for these patients. As I mentioned before, when you get your diagnosis, you will see that yourselves. And the idea that palliative care could be linked into comprehensive cancer care, meaning you are treating them with chemotherapy, radiation, and surgery, yet on the side, there is a palliative care partnership traveling along with you. They have fewer palliative needs in the beginning, but as their disease progresses, they may have more. Ultimately, the idea would be if you got to the point where there was no further treatment available, useful, or beneficial to the patient, that your palliative colleagues would have already been alongside you. You wouldn't be giving up or leaving them. You would be handing them over to continue the comprehensive care that you've hoped they would have from the beginning. Prognosis, I'm coming back to because I think it is at the heart of where we are, this statement about how we, in some ways, have gotten, in the old days, I guess maybe we would not have much in the way of diagnostics. We weren't very good in therapeutics, so the job of doctors was to sit at the bedside, hold someone's pulse, and say how long they might think they have. And that was a useful thing that doctors did. Well, as we've progressed in the world into diagnostics and therapeutics, some people would say we've atrophied our prognostic skills, and so now we don't step up to the plate in the same way, giving people prognostic information. So, for instance, this is a study that was done out of Chicago a few years back. Nick Christakis, as you note, is talking about hospice patients. So the diagnosis is actually already in for these patients. There's not any uncertainty. They've already enrolled. And there's a lot of them, 300 plus patients, and a lot of different doctors involved in his study. So what he did was he asked the doctors involved in certifying these patients for hospice, how many days they thought their patient would actually live. And the doctor said on average around 75. He then said, what are you telling your patients or their families? And they would say, well, it'd be better to say 90 because that sounds better than 75. It just gives them more hope. And then as he showed in his study, the actual survival was less than a quarter or a third of what they had predicted. And so it gives you these statements, which would worry us as doctors, so that we would never believe that we weren't trying to give frank information or giving inaccurate information. And then there was a pattern of giving no prognostic information, meaning only God knows kind of answer. And that's is what his study showed us, and many of us think that might be problematic. So the other argument, although often, is if we just stay positive, our patients will do better. So I would think of it this way, or do think of it this way, that in any group, a spectrum of patients that we're taking care of, there are going to be a variety of different ways of looking at life. Some people are going to say, I will do anything you say, I want to stay alive no matter what. And if you have a 34-year-old woman with breast cancer who's dying and 2 small children, she is going to stay in there no matter what. Other patients have quite different views about how they would want to spend their valuable time. I think, and you would probably know, that if you give them realistic information, that people will then make their own judgments about how they spend their time. I would briefly segue to say how I got into palliative medicine from a primary geriatric work that I've been doing for years, was work on an ethics committee, in that when I got called in, it sounded like there was a pattern that we as the healthcare system weren't really telling our patients the whole story. And it got to be, in my mind, if we were telling them the real story, a percentage of those patients would have made a different decision. They may not have been in hospital. They may have been home on their porch or spending their time in a different way. So I started to get this feeling that if we're not really being forthright or honest with our prognostic information, in ways we're actually cheating our patients. I think they have the right to hear from us. Now, when in teaching residents and students and even working with the hospitalists, people will say, whatever you do, don't tell the patient their diagnosis or their prognosis, because they will roll over and die, which I don't think anyone's ever done, period. But I think the right solution to that problem when I'm teaching is to say, well, the patient always has the right to be asked what they want to know. And if they tell us they want straight information about the prognosis for their diagnosis, then you're going to give it to them. Some families, patients will say they don't want you to talk to them directly, talk to my daughter, or perhaps talk with both of us together. So that would be to me the answer to that. Don't tell them, they won't be able to tolerate the news. But I still think you're obligated to make that effort to get prognostic information out for patients to make their own decisions about how to spend their time. So as all of us know, the hospital is a way stop for many of our advanced cancer patients, somewhere in their hospitalization, somewhere in their treatment course. And this is rather notable that this many patients spend time in the hospital. And the ICU is certainly not an uncommon stopping point. Often a question, if you're on the hospital side, which is where I am most of the time, you wonder when you see a metastatic cancer patient in the ICU, how that came about, and could we do better? What's the likelihood they're going to benefit from the intensive care unit at this point in their trajectory? So I'd consider this. This is sort of a challenge, I think, to all of us, but I wonder, Sharp Healthcare owns their patients. They're a large HMO in Southern California, but they make this claim in their oncology program that 0% of their advanced cancer patients are cared for in an acute care hospital. That's pretty stunning. It's always gotten me interested in how they do that. It's a very aggressive program they have for outpatient, community-based, office-based, combination of oncology, palliative care, community workers, home health services. They've realized the benefit, obviously, because they've saved money doing it by keeping their patients out of the hospital. But as many of us would know, most of these patients are not well served in the hospital. It's unwanted for most of them. They would be grateful if they weren't in our hospitals generally. At this point, there's no way around it. MedStar Health is not able to provide that kind of intervention for our oncology and from our oncology and palliative care programs. I do wonder, seeing as I spend my day now here at Franklin Square Hospital, often seeing oncology patients, if there weren't very many of them, would that leave me more bandwidth with my team to go out the door and see patients in your offices or do the community-based version of palliative care? Yes, the answer would be yes, and I hope it's the direction we're working towards. I know many of you support this already. Mr. P is a cancer patient admitted to this hospital. He actually back in December of 2019 diagnosed with two tumors, two cancers, both a large and a small cell cancer, has actually been very successfully treated for 9 months. Presents ultimately to the emergency room feeling poorly with back pain. He's found to have a pneumonia, but more to the point, imaging shows widespread disease, bony mets in the spine, liver mets, brain mets, lung involvement. So he's probably run out of good fortune in terms of one of his tumors, and he is now admitted to hospital for treatment. I guess he's symptomatic, unsurprisingly, an area where palliative care and oncology overlap often, I hope, collaboratively, that he has certainly other symptoms that are notable when you meet the patient. He's actually fairly angry at being in hospital, and I had the opportunity, I guess, thinking of all the people that are working with him. He's under the care of a hospitalist. He has pulmonary consultation. There's nursing, the usual array of hospital care. But I asked him what he's been told about his condition, and he basically says, I have pneumonia. I said, has anybody told you anything else? And he says no. And I then said, well, there is more information. How do you like your information? Should I be talking with you, or should I wait and talk with family members and you? He said, no, tell me. So I had to give him at least some details of what these CAT scans were showing and explain to him why his back was hurting so mightily with a lot of cancer now in his back. It was news to him, and it was taken, I would say, not easily by him. However, I had to say to him, I thought he had the right to know what we were worried about, and that how we would now work together to try to continue to treat him. So I guess the reason I'm bringing it up is there wouldn't be totally unusual for a patient to wind up in hospital with deterioration of their overall condition. What are we telling them when they arrive here? What is the family knowing? And then how is that compared to what we're actually talking about at the nurse's station or back in our own offices about the situation? There's obviously probably a disconnect, and in these cases, always for me as a palliative care physician, I really always prefer to have my oncology colleagues with me. I like to be able to say I've talked with my oncology colleagues about what the next steps are, and obviously, to the extent possible, have you come join us for care for these patients in the hospital. The trust issue I put down at the bottom because it's such a common theme for us. The healthcare system as we know it is unfortunately pretty fractured. There's a lot of different people involved, so as they become your patients, you in some ways are the primary care doctors. They arrive in hospital, there's suddenly a whole new array of people taking care of them, and trust is an issue. I think it can be bridged. I think it's bridged by communication. I'm often thinking, as I see patients in hospital, that they're looking out at us, thinking we are all working together. I'm not certain that is always the case. I think we always can do better, but I think the service to the patient in giving one voice is the overriding principle that we should adhere to. So here he is. He has this aforementioned deeply held desire not to be dead. It wasn't clear to me how really well he understood what I was telling him in terms of what this meant with disease now spread throughout. And I wasn't sure at all what he was telling his family or his wife in this case. This first point, I think, became more and more apparent to me in my practice in palliative care, that as you continue to care for these patients, in many ways you become their primary care physicians. You are literally the best, most knowledgeable and most involved with their care. And to the extent that ultimately they may not have beneficial treatment, the idea that at some point you're not going to continue treatment may feel or may seem to you, I think, as human beings taking care of other human beings, that it could be abandonment. I think that's real. I think it needs to be acknowledged, and I think you work around that all the time. But I don't think it goes away. I don't think it'll ever go away. I, as a primary care doctor, had exactly the same ownership of my patients, of feeling like their health care belonged in some way to me, and I couldn't let them down. In oncology, to some extent, I'm worried that continued chemotherapy may actually be the way that you show that you still care, and if you're not willing to continue chemo, for instance, it may be interpreted more by you or by the family or them that you don't care anymore. Obviously not true, but a common challenge. I see in the hospital, frankly, this image of once someone gets their hand caught in the door in the emergency room, they get dragged into the hospital, and many things happen that are maybe unexpected, maybe unwelcome, maybe not even beneficial, but they're part of the medical, complex here at a hospital. I worry that ultimately people keep doing what they've been doing because they don't know what the alternative is, and the alternative sounds worse than anything, that you're going to throw me out on the street and that I'll die uncared for. So I think that the concept that at some point the alternatives to continued aggressive therapy have to be clearly stated. What will that look like? How will we continue to care for you? And that has to be supported, in my mind, by the oncology community as much as anybody. That's my job as a palliative care and ultimately as a hospice referral to do that. But it has to come, I think, with permission from you all. So I would think about this. How do you actually get into these conversations as you have so many tasks in front of you in your offices for care of these patients, many boxes that need to be checked? How are you going to donate time to this aspect of oncology care? I guess I did this in my geriatric practice, a variety of this anyway, wherein I had some 800 geriatric patients for years, and I made a mission to talk with all of them about their wishes. And over time I was able to do it. I got it down to a reasonably short period of time, a short talk, 7 minutes or thereabouts, and I thought, in general, all of my patients actually appreciated the fact that I was respectful to them. I brought up the idea of talking about their wishes, what they would want for themselves, and that I would respect those wishes. So I put it this way. I would often say, well, if you fell over in the giant parking lot and you were unconscious, who's going to show up, in the hospital to help us care for you, to make decisions for you if you were no longer able to? In our hospital setting, it's fairly common for our patients and advanced cancer patients to be pretty darn sick and not be very capable of directing care. So I think the question, who will do the talking, and then this question, do they really know what you want? What would you expect? Again, I don't meet daughters who want to lose their mother, husbands who want to lose wives, but have they had a real conversation with that daughter or with that wife about what they would want depending on what the circumstances were, what their chances were, what survival would take, and what it would mean? So I think advanced directives is not a thing that you're spending a lot of your daily time in, I think, in your oncology visits. But I think it is actually a good way to get into this topic, and whether you do this or someone else in your office, or ultimately a palliative care colleague or team working with you would get involved with this. Very briefly, because this topic sometimes gets a little vague to people, when you think about advanced directives, there's actually two parts to an advanced directive. The first part, in my mind, is the most important part, this appointing of a healthcare agent. We used to call it power of attorney for healthcare, but that was a little confusing, so healthcare agent. The patients can do this at the kitchen table. They can do this in your office. There's no requirement for a lawyer. There's no requirement for a notary. The patient has to tell us who they think would make the best decisions if they were unable, if the patient themselves were unable, who would be best able to carry out the patient's wishes. And after they determine that, the document needs to be signed by the patient, capacitated patient, and then two witnesses over the age of 18. Anybody who is not the patient, the person who's being given authority, healthcare authority, can sign it. Healthcare professionals are often recommended not to do it. I don't usually do it. My social worker will do it, though, and other people in medical offices do it all the time. Appointment of a healthcare agent is what most people would say is the smartest one step we can take. And then the question is, have you told that person what you would really want given circumstances? So the second part of a healthcare, an advanced directive would be the, used to be called living will. That also was confusing to people. It confused it with a financial will. So it's now been, in state of Maryland, just called healthcare instructions. And that's the document that says, if I get in this shape, I would want that done. If I'm in a terminal condition, I would want X, Y, and Z. I'd want a feeding tube. I wouldn't want a feeding tube. That out for me. They use it as a template to talk with their loved ones. They can certainly fill it out, and people have opinions about that. So these documents are widely available, state of Maryland version. There's a lot of other ones. People are familiar with one called 5 Wishes, which is a little more patient-friendly and easier for families to read through. And it talks about other kinds of preferences that patients and families may want. So I bring this up because I think it is a way to start the topic with more seriously ill patients about their wishes. I think they get between the lines why we are asking them these questions. And in my experience, it often leads then to real discussion about what things may be coming, what options are ahead of them, ones they may or may not choose. And therefore, I think the dialogue can be started. I don't always expect patients to arrive back at my office or your office with a completed advanced directive, although sometimes they will. But I think if we've allowed them to open up that conversation, you may find that there's more questions coming your way, and allow us to talk more personally about what may be ahead of a patient for their medical oncological care in the future. I have 3 questions that I'm often asking patients, again, as I'm hospital-based, that's where they tend to be, but I think they work everywhere, and I recognize them to be simplistic appearing questions, but it turns out that generally I find out more than I ever think I'm going to by asking questions like this. So these are the questions that I often ask, and it really is most commonly the second one, which is, what are you worried about right now? I ask that in almost any interview where I see patients. They don't often really even know me at all. I can be a complete stranger, and yet they will answer that question. Sometimes, as we are human beings, we don't always trust the person who's talking with us so much yet. They might only give me part of an answer. I have often found that what people say to me the first time I ask the question isn't the whole answer. So sometimes I would then, in this very brief interview, might suggest to them, tell me more about what you just said, and it's not uncommon for them to tell me something quite different than I thought they were telling me to begin with. So, for instance, I would say, what are you worried about? They say, well, I'm worried about dying. I said, well, okay, that's pretty obvious. You've got, I don't say it, but I'm thinking they've got advanced cancer. But then I say, well, tell me a little more. Why do you say that? They say, well, I'm not worried about dying now, but I'm worried about things that will happen down the road when I really am dying. So it allows you to kind of broaden the conversation. So I think that a very simple question of asking people what they're worried about now also allows you maybe to solve what seems, it may not be so esoteric or maybe existential as dying. It might be just something simple that can be solved, like I'm worried about how I'm going to get home after this visit, or something more mundane that we can help and solve for our patients. So I think it's a good question. I think it works often well to get people to tell you what they're really thinking. The other question I will ask is, what do you hope for? And sometimes that sounds a little odd to a patient who may be seriously ill with a serious diagnosis. But patients always do hope for something, and I sometimes remind them, a miracle. Sure, we're in favor of miracles, not in charge of miracles. They're rare. I say I'm often challenged by that question. I've started to adopt this answer for religious people who appeared in front of me, often saying, I hope for a miracle, and I'd say, for my mother, and I would say, well, you might want to consider you've already seen some of the miracle with her life, so I get out of it that way. However, I do say, in case there isn't a miracle, we have to plan for, so can you tell me other things you hope for? And most people will say things you would expect. I hope I will not be miserable for whatever time I have. I hope my family's all right. I hope I'm maybe not in this hospital. I hope I'm home. Those are common things. So typical for truly more seriously ill patients. However, I think it's even a question that can be asked earlier and in our care of patients. Fear is another one, and I do ask patients, are you afraid? And it's not uncommon for people to say, I'm not afraid if I die, then I'm gone, but I am afraid of what might happen to me along the way. And there is our opportunity. I say, we will continue to care for you regardless with your oncologist, to care for you in the best way we can for as long as you're here. So those are common questions that you might consider part. I now go just a little off the track. Many of you probably know me. I've been here for quite a long time. Dr. Fowler and Dr. Farha talked me into giving this talk, and I told them it may be the last time I talk because I'm likely to be leaving MedStar fairly soon, but I have to take the opportunity then to cast some philosophy upon you as well. And so this is stolen, like most of my information, which I always tell my residents, feel free to steal from me. Cassell wrote about this, and he talked about suffering. And as oncologists and palliative care specialists, we are often involved with human suffering. So he wanted us to think about suffering in maybe in a little bit broader terms. So he said he liked to think about personhood, whole person thinking. And he said that the people who appear in front of us every day in our offices or in the hospital actually are quite complex, and they have many facets. So all the people we see today come to us from a past. They have a history that is ingrained. It guides how they're going likely into the future. Part of that may be their experience with their own previous illness, maybe even a previous cancer that they beat. Or maybe it was a previous illness from their family of cancer where this or that happened. So it informs how they think, how they proceed in many ways. These same patients have their family, as we well know, for better or for worse, and however they define their family, as we also know, is who their family may be. So these are very important people to them and ultimately to us when we're caring for these people. They come typically from a cultural background, which also shades how they view illness, how they view treatment, how we speak to one another. All things are dictated in many ways by culture, and we are now obviously in a multicultural world. These patients, like us, have roles. We on this talk today are healthcare providers. We're doctors, or we are nurses and nurse practitioners. We see our lives that way. That's how we work our interpretation of the world. We all have a very distinct relationship to ourselves. It started a long time ago. We have to look in the mirror. We have to believe we're being ourselves, true to ourselves. We, maybe even more now, are political beings. We are somehow involved. It could be in our hospital, in our office, in our community. It could be national. We have lives and things that worry us or inspire us. We have a life that is unconscious, that travels somehow below the surface, but as we all know, very much affects us, even if we're not aware of it. We have adopted behaviors, things that we just like to do. You like to have your coffee in the morning. You like to get up and run around the block to wake up. Those are important behaviors that we think are integral, to our health and to our daily worlds. We have a physical body that we have always depended on. It is our vessel to get about the world and do the things that we need to do. We depend on our body. We have secret lives. This is not necessarily going to show up in front of us healthcare providers. However, it is possible when people are more seriously ill that secret lives start to become less secret. So they exist for everyone and can be a real factor. And finally, all people have some form of spiritual life that guides them in our world. We hope it's still supporting them when other things become more difficult. So the question or the issue that Cassell brings up is that he postulates that suffering is caused by the disintegration of the person. The fact that the personhood comes under attack is what causes human suffering. So when you become a person who no longer can be active in any kind of political life, you have started to lose a little bit. Your behaviors, your common practices, suddenly they're not so easy for you to accomplish. So you lose them. They become a loss. A role. I'm a doctor. If I can no longer practice medicine or take care of patients, I'm diminished. If I'm a father and can't help my children, if I'm a husband and can't act as a husband, I'm diminished. I am losing ground, and I suffer for that. My body, I've trusted all along, is now in cancer, for instance, under full attack. the things I used to trust aren't working anymore, are betraying me. The things that are important in my background, my cultural background, are starting to fade because I'm starting to be overwhelmed by that. So as you see, each one of our personhood aspects starts to come apart, secret lives. So the point that Cassell would want us to think about, and the reason I'm bringing it up to all of you in your more philosophic moments, is that because all our patients are undergoing a type of disintegration of their personhood, the remedy for some of that suffering is reintegration. So how do our patients reintegrate or salvage the remaining parts into an integral human being, and therefore are able to continue on with their lives? I don't think any one of us can do this for one patient, but I think we can be aware of what's happening and we can call on others to help us. We are multidisciplinary in palliative care, so a social worker, as you well know with your navigators, the social worker is so important. Spiritual care, very important for the seriously ill. We like our pharmacists because they help us with medications when they are part of the suffering continuum. So I bring up this last point just because I always like to say to families who are really seriously grieving or anticipating what is going to happen, that in my world there's still time. There's still time to talk with your loved one, and there are 5 things that are always recommended that we should, if we give our patients or families a chance to say to one another, it's a gift. And so those things are often in any order. Thank you for all that you have done for me as my mother. Thank you as my wife. Forgive me for when I was not a perfect husband or perfect father. Few of us are. I forgive you when you were not perfect. These first 3 are very important in my mind and very difficult because a lot of challenges revolve around human interactions with these issues. Give someone an opportunity to say is something as important as I love you. And finally, for those who can do this, the idea of saying goodbye to someone who they may never see again is in some ways a gift as far as I'm concerned. Thank you for the opportunity to talk today. Please continue your best work as you have been doing, and I hope my palliative colleagues will continue to support you in all of that work.
Hi, my name is Dr. Mahsa Mohebtash. I am the medical director of Franklin Square Cancer Center at Lockhaven. Today I'm talking about monoclonal gammopathy, and please post your questions on the comment box and I will answer them once finished. Thank you. So what is monoclonal gammopathy? Monoclonal gammopathy has 2 other names: plasma cell dyscrasia or paraproteinemia. It is caused by proliferation of abnormal clone of plasma cells or B cells. It includes a wide variety of diseases. Actually, it can be a spectrum. It can be symptomatic or asymptomatic. So in this picture, we see plasma cells. That is how they look, and it's a picture of bone marrow aspirate. Plasma cells produce immunoglobulins, which consist of 2 heavy chains and 2 light chains. When they become clonal and expanded, they produce monoclonal proteins, which can be a whole immunoglobulin or just light chains. Light chains can be kappa or lambda light chains. So what is multiple myeloma? Multiple myeloma requires more than 10% plasma cells infiltration in the bone marrow or biopsy-proven tissue plasmacytoma, plus one of the following. It's very important to know that it has to be an end organ damage involved in multiple myeloma, besides having 10% of or more of plasma cells. End organ damages are hypercalcemia, renal insufficiency, anemia, lytic lesions, or as abbreviated as CRAB, to remember. So there are some other criteria or biomarkers which are associated with near inevitable progression to end organ damage. And that's when you have more than 60% plasma cells in the bone marrow. It's very unlikely not to have end organ damage with this level of plasma cell infiltration. And the free light chain ratio, if it's more than 100, it's very unlikely that you do not have any end organ damage, or it's going to be very soon. MRI with more than one focal lesion involving multiple areas of bone or bone marrow, these are also suggestive of multiple myeloma. What is a smoldering myeloma? Smoldering myeloma is that when you have a large M protein, which is usually more than 3 grams, or 10 to 60% of bone marrow infiltration of plasma cells, plus there should not be any end organ damage in smoldering myeloma. And the light chain ratio should be less than 100, and there should not be MRI or other imaging finding of more than one focal bone lesion. Waldenstrom Macroglobulinemia. So multiple myeloma, it's either IgG or IgA, kappa or lambda, rarely IgD. When it is IgM, monoclonal gammopathy, it is Waldenstrom Macroglobulinemia or IgM MGUS. So when you have IgM monoclonal gammopathy and lymphoma infiltration in the bone marrow, that defines Waldenstrom macroglobulinemia. Symptoms are either related to the infiltration of tissue, which causes anemia, lymphadenopathy, hepatosplenomegaly, or effects of monoclonal IgM in the blood with hyperviscosity and peripheral neuropathy. We have an entity of IgM multiple myeloma, but that is extremely rare. So solitary plasmacytoma is tumors which are composed of plasma cells. And usually there is no bone marrow infiltration. Actually, there must be less than 10% of bone marrow infiltration. Very rarely you see solitary plasmacytoma with MGUS, but in general, it's just one area infiltrated with plasma cells. Unlike multiple myeloma, which is not curable, solitary plasmacytoma could be cured with radiation and local treatment. If solely it is in the bone, it is called solitary plasmacytoma of bone. If it's in soft tissue, it's called solitary extramedullary plasmacytoma. So as I said, it has to be 4 criteria to be met: biopsy proven, solitary lesion of the bone or soft tissue showing clonal plasma cells, normal bone marrow with no evidence of clonal plasma cells, and sometimes you can have minimal marrow involvement if clonal plasma cells is less than 10%. And the MRI and PET scan and other imaging is normal except for the primary solitary lesion. You should not have evidence of anemia, hypercalcemia, renal insufficiency, which are the signs of end organ damage. So light chain or AL amyloidosis. In AL amyloidosis, which is also called primary amyloidosis, monoclonal light chains, they form fibrils, which lead to end organ dysfunction. They stain with Congo red, and there should be less than 20% of marrow with plasma cells, no lytic lesions on imaging, and diagnosis is made by biopsy of the affected tissue. One thing to remember about amyloidosis is that amyloidosis does not have to be systemic. It could be organ limited. It could be involving 1 or 2 organs. So it's best if you can biopsy the organ which is involved. So usually it is abdominal fat, bone marrow, rectum, kidney, and endomyocardium that we biopsy. Rarely, multiple myeloma can develop in patients who have primary amyloidosis, usually in patients who do not have cardiac or hepatic involvement and who can live long enough to develop multiple myeloma. Conversely, the development of dipstick positive proteinuria. So remember, dipstick urine analysis does not detect Benz-Joyce protein, does not detect M protein. It only detects albumin. So if you see in a multiple myeloma patient that the UA becomes positive, their albumin drops, or there is edema or heart failure, suspect light chain amyloidosis or light chain deposition disease. So what is light chain deposition disease? It is, again, deposition of light chains in tissues, but the difference between light chain deposition disease and light chain amyloidosis is that light chain does not bind to Congo red and is usually predominantly affects the kidneys. If it affects glomerular structures, they can present with nephrotic syndrome. If it's predominantly affects tubular structures of the kidney, they may present with renal insufficiency. So like amyloidosis, light chain disease can be associated with multiple myeloma or other conditions like lymphoma or Waldenstrom. Heavy chain deposition disease is very rare, and it's production of M protein just consisting of the heavy chain or a portion of it without bound light chains. So there are three types of heavy light chain, and it's based on the class of the immunoglobulin heavy chain is produced, and it could be alpha, gamma, or mu. Diagnosis is by immunohistochemistry of the affected organ biopsy, which could be a mass lesion, lymph node, or bone marrow, which shows clonal population of B cells staining positive for heavy chain, but negative for kappa and lambda light chains. POEM syndrome. It's rare, but it's important to know because it can be very confusing. We all hear that multiple myeloma can cause lytic lesions, but the lesions here is osteosclerotic. So that's why some people call it osteosclerotic myeloma. It consists of polyneuropathy, organomegaly, endocrinopathy, monoclonal protein skin changes. The cause of POEM syndrome is unknown, although overproduction of inflammatory cytokines seems to be playing a role. And peripheral neuropathy is definitely required for this diagnosis and usually dominates the clinical picture. You should suspect it in a patient with polyneuropathy and evidence of a monoclonal plasma cell disorder. The diagnosis of POEM syndrome requires the presence of both criteria, which are mandatory, monoclonal plasma cell disorder and polyneuropathy, plus at least one major and one minor criterion. And the mandatory criteria, both are noted here. Major criteria is either sclerotic bone lesions, Castleman disease, or elevated levels of VEGF, vascular endothelial growth factor. Minor criteria is organomegaly, which are splenomegaly, hepatomegaly, or lymphadenopathy. Extravascular volume overload like edema, pleural effusion, or ascites should be present, but it's a minor criteria. Endocrinopathy in POEM syndrome excludes diabetes, and it's usually adrenal, pituitary, gonadal, or parathyroid. Skin changes, it's commonly seen in this syndrome, which is usually with hyperpigmentation, hypertrichosis, and plethora, acrocyanosis, and flushing. Papilledema sometimes is seen, thrombocytosis and polycythemia are also sometimes seen. So this is a picture, skin changes of a patient with POEM syndrome. You can see the skin lesions here, which is papules which are erythematous, and some hyperpigmentation here associated with maculopapular lesions. Cryoglobulinemia is also one of the monoclonal disorders. However, only type 1 and type 2 can be monoclonal, and it's a disease in the serum that precipitates at a temperature of less than 37 and redissolve, the cryoglobulin redissolve when they are rewarmed. Signs and symptoms are related to vascular occlusion by cryoprecipitate, which could be digital ischemia, livedo reticularis, skin necrosis, or purpura. There could be constitutional symptoms, fatigue, arthralgia, myalgia, weakness, or peripheral neuropathy. Remember, when you are checking for cryoglobulins, you have to make sure the temperature is warm on the tube, so the tubes are warm, because if it goes below 37, you will get false negative results because they are going to precipitate. As I said, there are 3 types of cryoglobulinemia. One is type 1, which are monoclonal immunoglobulins, usually IgG or IgM, and less commonly IgA or free light chains. And it's in general in the setting of monoclonal gammopathies like MGUS, multiple myeloma, Waldenstrom, or chronic lymphocytic leukemia, CLL. Type 2 is a mixture of monoclonal and rheumatoid factor activity and polyclonal immunoglobulins. And it's in general in the setting of viral infections, particularly hepatitis C infection. It could be also hepatitis B, HIV, and autoimmune diseases, especially lupus and Sjogren's syndrome, and some lymphoproliferative disorders. Type 3 is mainly polyclonal. It's a mixture of polyclonal IgG and IgM, and it's a setting of autoimmune disorders and sometimes hepatitis C. So now we are going to talk about MGUS, which is a monoclonal gammopathy of unknown significance. This is something that is usually diagnosed by primary care physicians, and it's very common. More than 3% of the general population over age of 50, they can be diagnosed with monoclonal gammopathy of unknown significance. It's more common in men. It's more common in African Americans. And it's usually an incidental finding. And it's when physicians are checking for other diseases like workup for anemia, or they find a lytic lesion, or they see chronic kidney disease, they want to work it up, they come across this diagnosis. It is asymptomatic, pre-malignant, clonal, plasma cell or B-cell proliferative disorder. It's defined by serum monoclonal protein of less than 3 grams, bone marrow, which has to be less than 10% monoclonal plasma cells. And this is the most important thing, absence of end organ damage. There should not be any CRAB criteria, lytic lesions, anemia, hypercalcemia, renal insufficiency, or hyperviscosity. A bone marrow evaluation can be deferred. Like if you are not sure, always go with bone marrow biopsy. But if the level of M-spike is less than 1.5, and it's a low risk, it's IgG and not IgA, and light chain ratio is normal, then you can defer the bone marrow biopsy and watch the patient. But be careful that if you have any suspicion that this can be something more serious, because 4 to 5% of multiple myelomas are oligosecretory or non-secretory. It means that they do not produce that high M protein. So you may miss it. So if there is unexplained anemia, unexplained renal insufficiency, just do not go by the number of M protein. And sometimes it could be just light chain disease. So if you don't check the light chain ratio and the light chain is ratio is very high or very low, you may miss the diagnosis of multiple myeloma. So there are 3 types of MGUS. One is non-IgM MGUS, which is most common subtype. It can progress to smoldering or symptomatic myeloma. less often to AL amyloidosis or light chain deposition disease. IgM MGUS is about 15% of MGUS cases can progress to smoldering or symptomatic Waldenstrom Macroglobulinemia, and less often to amyloidosis or lymphoma. Light chain MGUS is secreted M protein, lacks the heavy chain, and can progress to light chain myeloma or amyloidosis or light chain deposition disease. So we said MGUS doesn't cause end organ damage, but what are the risks associated with MGUS? So MGUS can progress to multiple myeloma at the rate of 1% per year. So that's why it needs to be monitored. It increases the risk of peripheral neuropathy, and the mechanism of peripheral neuropathy in monoclonal gammopathies in general is not well understood, but MGUS is a risk factor for that. It doesn't cause lytic lesions, but in the studies it has shown it increases the risk of fractures at 10 years with a hazard ratio of 1.6. So it is greatest for axial fractures. The risk does not differ by isotype of IgG or IgA, or even interestingly, M protein concentration at diagnosis. Fractures do not predict disease progression. And that's why we recommend DEXA scan and checking for vitamin D in patients with history of MGUS. It's also associated with a small increased risk of venous and arterial thrombosis, and the mechanism is unclear, but hypercoagulable state secondary to ongoing clonal plasma cell expansion and activity has been suggested as an explanation. There is an increased risk of malignancy in patients with multiple myeloma and MGUS, and they do not recommend any extensive workup for malignancy, just age-appropriate cancer screening program. So how do you manage MGUS? It can progress to myeloma at 1% per year. Rate may be slightly higher for IgM MGUS and slightly lower for light chain MGUS. Median survival of patients with MGUS is only slightly shorter than at the age of the matched controls. No treatment is required, and usually annual or biannual, twice yearly protein electrophoresis, serum-free light chain, CBC, creatinine, and calcium, and HMP is needed. Risk of progression for low-risk non-IgM MGUS, which is M protein of less than 1.5, and IgG subtype, and normal light chain ratio is only 5% over 20 years. So you can screen them and monitor them at the longer intervals. So when should we screen for monoclonal gammopathy? When you have unexplained symptoms and signs of peripheral neuropathy, pathological fractures, Raynaud phenomenon, and acrocyanosis, hyperviscosity symptoms, heart failure, which is unexplained, or peripheral edema, which is unexplained. When you have unexplained laboratory and imaging findings, it could be normochromic anemia, high SED rate, elevated serum viscosity, elevated total protein, proteinuria, hypercalcemia, osteolytic lesions, recurrent infections, hypo or hyper gammoglobulinemia. How should we screen for monoclonal gammopathy? You need only 3 tests to screen for monoclonal gammopathy. You only need serum protein electrophoresis, serum immunofixation, and serum light chain. You can replace serum light chain with urine electrophoresis. Once one of these become positive, then you have to go to the second line and do more workup. You have to collect 24-hour urine for protein electrophoresis and immunofixation, CBC, creatinine, calcium, and immunoglobulins, IgG, IgA, IgM levels. And then you have to confirm the diagnosis with a bone marrow biopsy and aspirate, if needed, again, depending on what type of MGUS you run into. Bone imaging, fetal survey, PET scan or MRI, echocardiogram, or if needed, cardiac MRI. Thank you for listening to my presentation. Please don't forget to put your questions in the comment box and I will respond to them. Thank you.